Cancer statistics in the United States, as seen here for the incidence and mortality of melanoma, are compiled into what is known as the SEER database by a joint effort on the part of the National Cancer Institute and the Centers for Disease Control. As this graph of melanoma incidence and mortality shows, since 1980, the incidence of melanoma has increased by 128%. In looking at the graph, though, there is a significant anomaly. Over 30 years, mortality from melanoma remained completely unchanged, despite more than a doubling in incidence. And those mortality statistics are accurate. The CDC audits its stats to ensure that, and for melanoma, that accuracy is greater than 90%. And that trend in incidence for melanoma has continued to the present, with rates for men increasing 300% from 1980 and women 225%, again with virtually no change in mortality, despite the introduction of immunotherapy beginning around 2010, which has shown life-saving results for individuals responding to treatment, but unfortunately at the population level has shown only a marginal decline in mortality, which has remained essentially constant thereafter. So, how did this begin? Between 1970 and 1980, there was a slight increase in the incidence of melanoma that was accompanied by an increase in mortality. That naturally prompted an increase in awareness on the part of dermatology. And 1980 was the year that Wallace Clark published his famous paper defining the dysplastic nevus syndrome, which he stated was phenotypically associated with melanoma. Clark observed 7 patients with melanoma and large atypical nevi with histologic dysplasia and conflated this with the familial melanoma syndrome, conceiving the dysplastic nevus syndrome. Clark stated that dysplastic nevi are identical to the precursor lesion for melanoma, and that while the syndrome was first recognized in patients with 200 or more such nevi, presentation with 10 or fewer, or even a single nevus, was not uncommon. A year later, in 1981, Dr. Mark Green, a co-author on the dysplastic nevus syndrome paper and the senior clinical epidemiologist at the National Cancer Institute's Division of Cancer Cause and Prevention, stated to a meeting of the American Cancer Society that dysplastic nevi appear to be premalignant lesions. Then he went on to say that removal of the most abnormal nevi constitutes primary melanoma prevention. And with that, the dysplastic nevus syndrome had the imprimatur of the National Cancer Institute. 2 years later, NIH convened a consensus conference on precursors to melanoma. They concluded that evidence suggests that melanomas can arise directly from dysplastic nevi. With that in mind, we went looking for melanomas in atypical moles, and we found them. Heightened awareness changed to increased screening for melanoma, and by 1995, the incidence had increased almost 60%. Melanoma was increasing at an epidemic rate, but there was no associated increase in mortality. And that was striking, as in any 5-year period, there's significant mortality from melanoma, and in any 10-year period, there's substantial mortality, including significant mortality from early-stage disease. Yet, despite a 57% increase in melanoma, neither in any 5-year period nor in any 10-year period did the death rate from melanoma increase. It appeared that we had actually eliminated any and all increases in deaths from melanoma above that seen in 1980, and that raised a fundamental question. With almost a 60% increase, did we diagnose and successfully treat melanoma at a rate that, on a year-over-year basis for 15 years, exactly matched the prospective death rate to main mortality at a precise, irreducible minimum? That seemed improbable, and in 1997, Dr. Robert Swirlick, now retired chair of the Department of Dermatology at Emory, and Dr. Sufi Chen, the current chair at Duke, raised that question in a paper published in Mayo Clinic Proceedings. Citing the increase in the growth of melanoma incidence without any increase in mortality, they concluded that, because of attempts to detect and remove melanomas earlier, we'd increased the sensitivity of our clinical exam and were removing pigmented lesions with subtler clinical changes. The increase in melanoma incidence was specious, an artifact of diagnosis comparable to that had been seen with prostate and thyroid cancer. Malignant pathology under the microscope did not correlate with malignant behavior. Melanoma was being overdiagnosed. There was no melanoma epidemic. The proponents of screening's rejoinder to that was that they had kept prospective mortality down, and we weren't sufficiently engaged in a screening effort that would reduce it. Older practice patterns prevailed, and better trained and motivated clinicians, with pathologists now sensitized to making an earlier diagnosis, would reduce mortality going forward. Being handicapped in the ability to detect thin melanomas early enough to reduce mortality was also a major issue. They asserted that the melanoma epidemic was real, and that more aggressive screening would improve earlier detection of melanoma and reduce mortality. That view prevailed, and with a major public awareness campaign, including national media attention, coupled to an emphasis for clinicians to screen for melanoma, the effort to stem the melanoma epidemic and reduce mortality ensued. Then, in the mid-1990s, we received the holy grail for early detection of melanoma, the dermatoscope. The proponents of dermoscopy proclaimed that it could provide a definitive diagnosis of melanoma with a sensitivity of 100%. With practitioners and the public engaged and armed with the dermatoscope, the war on melanoma began, and it was highly successful, doubling the detection of melanomas over the next 15 years. The incidence of melanoma climbed to a startling 128% of its baseline prevalence in 1980, but mortality remained completely unchanged. The screening effort that resulted in the marked increase in the diagnosis of melanoma was not without criticism, echoing Swirlick and Chen's conclusions, citing error amplification from inappropriately increased sensitivity in diagnosis, that, similar to prostate cancer, the pathologic diagnosis of malignancy was unfounded, questioning whether we were just catering to the worried well, and giving people a diagnosis of a prospectively fatal malignancy that they had to live with, never knowing if or when incurable metastatic disease would present. The epidemic rise in invasive melanoma was only half the problem, though. Melanoma in situ was also rising at an epidemic rate. Just as the biopsy of nevi, previously presumed to be benign, increasingly revealed melanoma, biopsy of common lentiginous increasingly disclosed melanoma in situ. MIS, a relatively rare diagnosis before 1980, began to grow at a rate that paralleled the epidemic rise in invasive melanoma, then accelerated to eventually reach parity in incidence with it. By 2013, the incidence of melanoma in situ and invasive melanoma combined resulted in a 250% increase in the incidence of individuals diagnosed with melanoma in some form. Mortality from MIS is negligible, and in fact, overall, the lifespan of patients diagnosed with melanoma in situ is statistically greater than that of the general population. However, surgical treatment for MIS is essentially identical to that for invasive melanoma and isn't trivial. And whatever reassurance the patient is given regarding the prognosis for the in situ diagnosis, what patients hear is they have a melanoma. Given the equivocal evidence for melanoma in situ being a precursor to invasive melanoma and the negligible mortality associated with MIS, melanoma in situ isn't included in the SEER statistics for melanoma. A diagnosis of melanoma in situ for a patient, however, is neither equivocal nor insignificant. The U.S. wasn't the only country experiencing the melanoma epidemic. Germany was similarly affected and plagued by the same question of the discordance between increasing incidence and unchanging mortality. They decided they would settle the issue once and for all. They would screen and follow the entire population of 85 million people. What they found was no decrease in melanoma mortality, and questioned whether the screening program had any benefit at all. In the U.S., meanwhile, the screening effort did validate an important conclusion of the Mayo paper, that if aggressive screening was the cause of increased diagnosis of melanoma, more aggressive screening would increase it further. Swirlick and Chen stated that screening was only half of the epidemic issue, though. Overreading the pathology of pigmented lesions was an equal contributor to melanoma's overdiagnosis. Pathologists had been expected to heighten their sensitivity to diagnose melanoma to catch it at an earlier stage. However, as with any test, a gain in sensitivity is always accompanied by some loss of specificity. The criticism that there was a high degree of variability in the pathologic determination of melanoma showed up even before the Mayo Proceedings paper. Discordant interpretations of melanoma were high, with over a third of expert pathologists differing in opinion as to whether a lesion really was malignant. The Journal of the American Academy of Dermatology published several studies citing the high degree of variability among pathologists interpreting melanocytic lesions as benign or malignant, and that because of the subjectivity interpreting melanoma, on review, a lesion might actually be reclassified as completely benign. Validating a subjective drift in the diagnosis of melanoma was a study from Mass General Hospital. Slides from 1988 through 1990 read as either melanoma or severely dysplastic nevi were selected for a review 20 years later by dermatopathologists, including all of the original dermatopathologists. The number of dysplastic nevi reread 20 years later as melanoma increased 64%. However, it wasn't any or all melanomas that were driving the melanoma epidemic. The Mayo Proceedings paper singled out the upsurge in the diagnosis of thin melanomas as the driving force behind the epidemic increase. Under the microscope in 1976, the median thickness of a melanoma was 1.8 millimeters. By 1990, however, Half of all melanomas had a thickness of 0.75 millimeters, less than half that of the pre-epidemic era. And by 2000, the median thickness had decreased to 0.5 millimeters. That trend was noted in a number of critical articles over the next decade, raising the question as to the fidelity of the diagnosis of melanoma when histopathologically assessing thin lesions. That the source for the decrease in melanoma thickness was led by clinicians was documented in a study in the journal Cancer. Individuals who presented with concerning lesions they or their spouse had found when then diagnosed as melanoma were relatively thin. However, when dermatologists identified a suspicious lesion that a biopsy then showed to be melanoma, those melanomas were even thinner, less than half the thickness of the self-identified lesions patients presented for. Clinician-diagnosed melanomas averaged only 0.4 millimeters in thickness, an ultra-thin melanoma. The decreasing thickness of melanomas tracked the increasing incidence of melanoma over 20 years, down to that 0.5 millimeters in the year 2000, 75% thinner than pre-1980 tumors. And that 2000 measurement of 0.5 millimeters being a median value meant that half of all melanomas diagnosed in 2000 were even thinner, ultra-thin melanomas, with some bordering on the thinness of melanoma in situ. With roughly a 4% year-over-year rise in the fraction of melanomas contributing to the increased incidence of melanoma, thin melanomas comprised the bulk of the increase in the diagnosis of melanoma. We were ostensibly in the midst of a thin melanoma epidemic. However, a decade before we reached that point, objective review of both thin melanomas and melanoma in situ by expert dermatopathologists resulted in significant alterations in diagnosis, staging, and prognosis of these lesions, questioning whether the thin melanomas creating the melanoma epidemic were actually melanoma at all. Which brings us to the fundamental problem underlying the melanoma epidemic, and that is melanoma itself. That despite identical characteristics, the biologic behavior of melanocytic neoplasms does not correlate strongly with either clinical or histologic appearance, and the narrow focus on tumor thickness militating for the search for thin tumors that has led to the melanoma epidemic is challenged by both data and example. The data disclose that there is both short-term mortality in early-stage disease and significant long-term survival in patients presenting with advanced tumors. Thick or thin, the biologic behavior of any melanoma is largely biologically predetermined. The assumption that diagnosing melanoma at its thinnest will reduce mortality is belied by these statistics and exemplified by patients in my own practice. This woman near 80, with this long-standing ulcerating melanoma on her thumb, declined treatment as she was the sole caretaker of her husband, a retired physician himself, an invalid and homebound. When he passed away, she returned for evaluation with prominent axillary lymphadenopathy. She was sent to the melanoma clinic at an academic center for surgical management that included a complete axillary node dissection. No metastatic disease was present, and the nose revealed only reactive changes. Despite ulceration and its presence for years, she was otherwise well when last seen. More dramatic is one of my first patients in private practice, a gentleman also near 80, who presented with a melanoma that had been present and enlarging for a decade or more. One didn't need a micrometer to measure its thickness. He presented only because, in his exact words, his wife said, "There's a dermatologist in town now. Get that damn thing off of there. I'm tired of washing blood out of the sheets." I complied with his wife's wishes, and he passed away several years later from a heart attack, tumor-free. Superficially or under the microscope, the behavior of melanocytic neoplasms doesn't correlate with appearance, much as is true for people, as illustrated by these two gentlemen seen in photos from 1969. The man on the left is Charles Manson, leader of the Manson family cult responsible for multiple murders, including the mass murder of actress Sharon Tate and her 4 companions. The physician on the right, on the other hand, has not killed anyone, at least not intentionally. In summary, as Swirlick and Chen stated in their Mayo Proceedings paper over 25 years ago, the melanoma epidemic is an artifact of excessive clinical and histopathologic sensitivity. A 100% reduction in excess mortality every year for over 40 years for a cancer undergoing a 300% increase in incidence is inconceivable, and a large number of people have been illegitimately diagnosed as having malignant melanoma. Skipping over the math, that tally can be extrapolated from the 1980 baseline incidence and stable mortality. On average, more than 26,000 people annually above that 1980 baseline have been diagnosed as having malignant melanoma, 1.1 million people cumulatively in the past 40 years. Using that same analytic framework, going forward from 2020, almost 50,000 people annually continue to be diagnosed with melanoma, a cancer they do not have. And returning to melanoma in situ for a moment, between 1980 and 2015 alone, MIS increased tenfold, with similar cost to individuals and the healthcare system, and most often with significantly greater surgical morbidity, particularly disfigurement, due to its predominantly head and neck localization. In sum, the war on melanoma over the past 40 years has had significant tangible and personal costs, and all without saving a single additional life. The consequences go beyond numbers. Cancer is the most feared word in both a patient's and a physician's lexicon. The biggest consequence of the melanoma epidemic is the impact of a diagnosis of cancer on an individual. There are material and experiential consequences to having the diagnosis of a prospectively fatal malignancy that no amount of reassurance can allay. By far, the greatest consequence of the melanoma epidemic has been over 1 million people living with an inaccurate diagnosis of malignancy. Then there is the very tangible cost of unnecessary care levied on patients, payers, and the public, who underwrite the prospective cost of the melanoma epidemic going forward, now at conservatively $50 million a year. The trend toward early diagnosis of such a cost without demonstrated benefit over several decades reflects on the professional training and judgment of the specialty and has reputational consequences for dermatology. Growing awareness of the overdiagnosis of melanoma leading to its questionable epidemic growth has reached public perception in a number of major media outlets. And as the specialty is characterized, not inaccurately in reputable media, as having one of the highest incomes and lowest demands on time among specialists, the latitude this affords should translate into a high degree of fidelity to precision in the management of all dermatoses, but especially the most deadly malignancy it commonly faces. There are also reputational consequences for dermatology within the House of Medicine. The growing criticism of the overdiagnosis of melanoma has become a broader professional issue, reaching the major national and international professional journals. In 2015, the Academy surveyed physicians as to their opinion of the specialty of dermatology. The response was, other than skin cancer, dermatologists do not treat serious disease. If the specialty is incapable of accurately assessing the most serious malignancy it faces, its reputation in medicine will be significantly eroded, especially as its specialty is not recognized or acknowledged 30 years of its own academic work, attesting to the specious nature of the epidemic it created. As Swirlick and Chen concluded over 25 years ago, the diagnostic trend resulting in a specious melanoma epidemic would be a source of considerable embarrassment, if not public outrage, should the medical community sound an alarm about the frightening growth of melanoma, only to find that it is an artifact caused by the efforts initiated for the sake of early detection. That has become a reality 3 decades later. So, how do we correct this? We all live by the prime directive of medical practice, first do no harm, but we have to recognize that an excess of caution is harm. And that excessive caution is measurable. In 1980, there was a 5-to-1 margin of lesions removed suspected to be melanoma from actual melanoma. By 2020, that margin had increased to 15-to-1, a 300% increase without any benefit in reducing mortality. Consider if we applied a 300% greater margin of caution to the diagnosis of breast or prostate cancer, increased screening tests, frequent diagnostic biopsies, and a more liberal interpretation of malignancy, leading to resultant definitive surgeries. That it is just the skin is not a consideration. The diagnosis of a prospectively fatal malignancy is still a diagnosis of cancer, with all of the sequelae of cancer that a patient has to live with. It is the excessive caution from the false presumption of a melanoma epidemic in 1980 that raised clinicians' fears of missing a melanoma and created the positive feedback loop that has led to the 300% increase in the diagnosis of melanoma seen today. As with any positive feedback loop, the only way to extinguish runaway growth is to break the cycle by stopping the behavior that feeds it. Very simply, the way to end the melanoma epidemic is to end the epidemic of the diagnosis of melanoma. And the way to do that is straightforward. Return to the conservative screening, diagnostic, and management paradigms of 40 years ago that achieved the same result with respect to mortality that we see today. And that is first and foremost a leadership issue. Dermatologists and pathologists at the working level can't be expected to revise the standards for clinical and pathologic assessment of pigmented lesions without definitive and forceful support from institutional medicine. The leaders of the medical academies, medical societies, professional associations, and academic institutions. Frontline practice won't change unless leadership has its back. At the working level, the remedial effort is straightforward. Biopsy only when there is a substantive degree of evidence that a lesion might be melanoma, and know that the pathologist reading that slide is equally critical in reviewing and rendering an opinion on a lesion being malignant. Clinically, we know what we are looking for. First and foremost, an atypical lesion with a reliable history of new onset. Secondarily, a change in an established lesion's size or character by reliable history or documented serial examination. It is change, not morphology, that is most indicative of melanoma. No one wants to miss a melanoma, but no one wants a diagnosis of cancer based on vague morphologic characteristics, clinically or histopathologically. The melanoma epidemic begins and ends in the clinic. Monitoring extant lesions brought to the clinic does not have to be the sole responsibility of the clinician. Patients who are suspicious of change can do that objectively and quantitatively with simple observation or serial photography at home. Instilling confidence in the ability to successfully self-monitor nevi can significantly reduce the demands on dermatologists' time. The most important change in management, though, may be perspective. When approaching pigmented lesions, frame the issues surrounding diagnosis and management objectively. Melanoma mortality hasn't changed in 40 years as a result of clinical efforts. Recognize that aggressive screening, the dermatoscope, molecular diagnostic testing, and a veritable war on melanoma have, despite the best of intentions, only created a mythical epidemic, and the investment in these diagnostic efforts has paid no return on survival. So think critically about the melanoma epidemic, and in doing so, consider Richard Feynman's first principle for critical thinking in science. Feynman was a Nobel laureate in physics and a member of the Manhattan Project, and addressing the graduating class at Caltech, he told them that when drawing conclusions in science, the first principle is that you must not fool yourself, and you are the easiest person to fool. The data clearly contradict the dogma of the past 40 years. There is no melanoma epidemic, and there never was.